Well, I raised my hand when he asked who had carpal tunnel, so, and I hope if I'm 92, I'm sassy with carpal tunnel too. But, okay, carpal tunnel syndrome rehab. First of all, definition, to make it simple, it's increased pressure or entrapment of the median nerve at the level of the wrist. And as it was mentioned, it's the most common upper extremity compression neuropathy. The anatomy includes the carpal bones making up the floor of the carpal tunnel, the transverse carpal ligament being the roof, and then 9 tendons along with the median nerve occupying the space. The lumbricals are often forgotten as part of the carpal tunnel, and I call them the drop-ins because they're not occupying space all the time, but when the fingers are flexed, they kind of migrate their way into the carpal tunnel area and also take up some of that space. The clinical presentation would be numbness and tingling of the thumb, index finger, middle finger, and radial side of the ring finger, along with pain, and oftentimes these symptoms are worse at night. People often feel like their fingers are swollen and stiff and painful. Advanced and chronic cases will also present with weakness and atrophy of that thenar eminence area. And functionally, people will often complain of dropping things, difficulty holding utensils, or buttoning their shirts. A lot of times these functional problems aren't necessarily due to the weakness, but also the sensation loss that they're experiencing. There's not one definitive cause of carpal tunnel. Any swelling or inflammation in the area that puts pressure or further crowds the median nerve. This typically develops slowly over time, but we do know that using vibratory machines or extreme temperature conditions can worsen or exacerbate the symptoms. The pressure can be either externally or internally, and women are 3 times more likely than men to get carpal tunnel syndrome. We do have clinical tests, and these provocative tests will replicate the patient's symptoms of that numbness and tingling and that electric type feeling along the median nerve distribution. The provocative tests we use are the phalanx, reverse phalanx, the Tunnel, and the Berger's test. The phalanx is when we put the patient's wrist in extreme flexion and we wait for that reproduction of those symptoms. The reverse phalanx is placing them in extreme extension, and then the Tunnel is that tapping over that nerve, reproducing the symptoms. The Berger's test, or the closed fist test, is specifically looking at the involvement of the lumbricals. The 4 lumbricals are those sausage-like muscles that take origin from the FDP tendons, and as the FDP tendons they take origin on the FDP tendons after they cross the palm. The lumbrical muscles will originate distal to the carpal tunnel with the fingers held in full extension. But all 4 lumbrical muscles lie within the carpal tunnel once the fingers are actively flexed. Cobb and Cooney did a test looking at the lumbrical muscle incursion into the carpal tunnel during finger flexion. And what they found was that the lumbrical muscles were distal to the proximal aspect of the hook of the hamate only for the positions of full digital extension and 50% flexion. Another study looking at power grip and wrist positions, and they found that making a fist increased the intertunnel pressure specifically more than variations of the wrist positions alone. So a power grip was found to elevate intertunnel pressure to that 223 millimeters of mercury, compared to isometric flexion of the fingers against resistance to 41. Wrist flexion increased it to 56 and wrist extension to 77. So what has been tried to treat carpal tunnel syndrome conservatively, and this list is very long. There's weak evidence to prove that many of these work or help at all. The steroid injections have been proven to give more long-lasting benefits of their symptoms, but many of these others have only proven to give short-term reduction in symptoms. Mitch Levis did a review of literature, and she cited really that it was difficulty to make conclusions on some of these interventions. But based on her review, she did recommend that patients with mild to moderate carpal tunnel syndrome would benefit from nighttime splinting, intermittent nerve gliding exercises, activity modification, and some pain relieving modalities. But other studies would show that other than the cortisone injections, which did give more long-lasting benefit, a lot of the other interventions provided only really short-term benefit or none at all. So the question really is, what is reasonable conservative treatment? And we have to keep in mind that what are we trying to accomplish when we're treating carpal tunnel syndrome? We're trying to get the pressure on the nerve off the nerve. And we really ought to look at, do any of our modalities, are they going to do that? Also, I like to think about the patient's history. What is going on in the patient's activities, work activities, or their past medical history that could be contributing to the problem? And do our modalities or what we can offer take that pressure off of the nerve? We do know that wrist position can increase the pressure on the nerve, and so it seems reasonable to me to try to get the wrist in a neutral wrist position, and especially at night when a lot of times patients will kind of get in an awkward sleep position for an extended period of time that could keep that pressure on the nerve for a longer length of time that we would not want. Specifically looking at the lumbricals, and if we do have, we do know that the Berger's test is positive and that fisting position, we could be looking at the lumbricals adding added pressure, or if we know our patient has a compulsive gripping type problem, some older people have that. We might specifically look at a lumbrical block splint where we're not allowing the patients to flex their MCPs, which would prevent the lumbricals from being drawn into that carpal tunnel and further crowding the area, the nerve. Edema control, again, if they're dealing with some kind of acute edema, or if we are only really trying to give them short-term benefit, some of our modalities may help, but really the studies don't support that so much. As far as the nerve gliding exercises, we kind of want to be cautious with that, because if the nerve does have a really firm entrapment, we could actually be causing further nerve injury by doing aggressive nerve glides. Patient education can always help our patients. We want to teach them about activity modification and avoiding those repetitive type activities, avoiding those extreme wrist positions, avoiding forceful gripping, because we know that that alone can really increase the pressure in the carpal tunnel area. Sustained gripping, and we would really try to avoid grip strengthening. Also, it's always good for us to teach the patients to be aware of their wrist postures while they're doing most of their work activities. So there may be times where really conservative carpal tunnel syndrome might not, or conservative carpal tunnel treatment therapy might not be appropriate at all. And sometimes when we all want to help our patients, but sometimes recognizing that we really can't help our patients and moving them and then referring them on is probably the best thing we can do for them. So if patients are really consistently waking up every night with numbness and tingling and pain, or not accompanied by daytime paresthesias as well, or if they already are showing atrophy of that opponent's pollicis muscle, our conservative treatment as a therapist probably isn't the answer, and we should quickly refer them on for either cortisone injection or the carpal tunnel release. So in doing my research on this topic, I asked some of the mid-levels, are there different types of cortisone injections? And I'm a believer in them. I had one myself 2 years ago, and I've avoided the surgery. And there are lots of recordable studies that prove that they help. And I said, are there different kinds? And basically they said no, but they can be given with different attitude. Here's the let me at you attitude with this big needle, and there's this won't hurt me a bit. And then there's Jeff's, I better get it right. So as we know, conservative treatment is not always the answer, and many patients experience temporary relief of their symptoms from some of our conservative approaches, and they will end up requiring decompression or surgical release. We often see our patients after carpal tunnel release, and this is not a statistic that's been documented, but I would say at least 50% of the patients, when we see them on their first post-op visit, they'll say, why did I wait so long? So the value, however, for carpal tunnel syndrome post-operative therapy is debated. So there was a study done in 2007 that's titled Outcomes of Carpal Tunnel Surgery with or Without Supervised Post-Operative Therapy. And this randomized study failed to show the benefit of a 2-week course of hand therapy after carpal tunnel release using a short incision, and concluded that the cost of supervised therapy for uncomplicated carpal tunnel release was unjustified. And what they said was the key to a successful carpal tunnel release was a short incision and an experienced hand surgeon. And to keep in mind that therapy would have no influence whatsoever on a nerve that was still mechanically compressed or the rate of regeneration of a recovering nerve. So at the Bone and Joint, we typically see the patients for a one-time visit only. They'll have their sutures removed in the doctor's office at 10 to 14 days post-op. At that point, we would teach them about scar massage and soft tissue mobilization to prevent scar adhesions or development of a painful scar. We would teach them about contrast bath techniques to help them manage minimal pain and minimal swelling as they begin to use their hands for more daily activities. We would teach them differential tendon gliding exercises to allow structures passing through the carpal tunnel to glide individually. And then teach them to gradually work into strengthening with normal activities and eventually hand strengthening with progressive putty. They may still need a wrist cock-up splint for higher risk type activities or repetitive type activities, just to prevent re-irritation to the soft tissue as they're healing. So we would give them these home programs. This is a pretty classic presentation on our first day post-op. There are a few patients that may benefit from more therapy depending on wound complications, really painful scars or significant pillar pain problems, hypersensitivity if they are having incomplete gliding of their tendons or stiff joints from previous osteoarthritis. So in conclusion, we really need to look at the patient's history and really make a clinical judgment as to whether or not, our therapy can help them with any long-term benefit, long-term relief, and therapy after carpal tunnel release actually a little goes a long way.